अहिले नबोलेको पनि हुन सक्छ नि तिनीहरू ए अझ सुरु भएको छैन त्यसमा
Hello everyone. And very good morning.
Good morning.
मेरो स्लाइड देख्नुहुन्छ तपाईले सबैजनाले सुनिरहनुहुन्छ अब हामी स्टार्ट गर्न जाँदैछौँ है आजको यो डेमो क्लास स्केड्युल तपाईले आफ्नो स्क्रिनमा देख्न सक्नुहुन्छ अब म चाहिँ सानो तपाईलाई ब्रिफिङ एकदम ब्रिफ ओरिएन्टेसन लिन्छु just 5-10 minutes then we'll get started with Dr. Rajesh Gubba. He's already connected with us है त ल अब let's get started है म चाहिँ डाक्टर अमृश थापा मेरो स्पेसियालिटी चाहिँ इन्टरनल मेडिसिन हो प्याराडाइस इन्स्टिट्युट एन्ड सेल्फ स्टडी सेन्टरको म एक्जिक्युटिभ डाइरेक्टर अब आजको हाम्रो तपाईलाई एकदम ब्रिफ ओरिएन्टेसनमा चाहिँ हाम्रो फ्याकल्टिज चाहिँ अब सबैले एउटा जिज्ञासा यो एमडीएमएस इन्ट्रान्स प्रिपरेसन कोर्स भनेपछि इट्स द हैन सरी अब यो चाहिँ एकदम स्पेशली दोज एस्पिरेन्ट्स हु आर प्रिपेयरिङ फर हैन एमडीएमएस प्रिपरेसन उनको लागि धेरै महत्त्वपूर्ण कुरा हो यो प्रिपरेसन हाउ इट गोज इट म्याटर्स अ लट इन देयर प्रिपरेसन त्यसले गर्दाखेरि चाहिँ अब हामीले चाहिँ अहिलेको नेपालमा हाम्रो कन्सेप्ट हाम्रो भिजन चाहिँ यस्तो छ कि नेपालमा यस्तो एमडीएमएस इन्ट्रान्स प्रिपरेसन होस् जुनले चाहिँ तपाईहरुले सोचेको एउटा एक्सपेक्ट गरेको त्यो हामीले मिट गर्न सकौं तपाईलाई हाम्रो कोर्सले तपाईहरुलाई हैन सेटिस्फाई गराउन सकौं भन्ने त्यो भिजन राखेर चाहिँ हामीले एन्ड नेपाली प्रोफेसर दुईटै कम्बाइन हुनुहुन्छ र इन्डियन प्रोफेसरबाट हामीले कन्फर्म गरेको अहिले प्रोफेसरहरु हुनुहुन्छ डाक्टर राजेश गुब्बा अनएकाडेमीबाट हुनुहुन्छ र अरु पनि धेरै प्लेटफर्मसँग आबद्ध हुनुहुन्छ त्यस्तै डाक्टर खलिल अहमद उहाँ चाहिँ प्रेपल्याडर र अरु अराइज र अन्य प्लेटफर्महरुसँग पनि उहाँ आबद्ध हुनुहुन्छ त्यस्तै हामी वी आर इन हैन कन्स्टेन्ट कम्युनिकेसन विथ अदर प्रोफेसर्स होपफुली विल फाइनलाइज भेरी सुन अरु इन्डियन प्रोफेसर्स पनि है त त्यसपछि अब ड्युरेसनको कुरा आउँछ अब यो चाहिँ हामीले चाहिँ हाम्रो कोर्सलाई चाहिँ अराउन्ड 500 आवर्स को डिजाइन गरेका छौं त्यसमा इट विल टेक अराउन्ड 5 मन्थ्स क्लास चाहिँ तपाईको 2 to 6 आवर्स अ डे हुन्छ एउटा क्लास चाहिँ नर्मली इट विल बी अराउन्ड 2 आवर्स त्यसपछि क्लास चाहिँ को हप्तामा चाहिँ अहिले चाहिँ थर्सडे टु सन्डे भनेर हामीले राखेका छौं है अब यसमा तपाईको सबै मेजर एन्ड माइनर सब्जेक्ट सबै कभर हुन्छ सबै तपाईले एमडीएमएस इन्ट्रान्स प्रिपरेसनमा चाहिँ को त्यो सबै कोर्सलाई हामीले यसैमा इन्क्लुड गरेका छौं सबै कोर्स कन्टेन्ट्स सब्जेक्ट्स है सबै कुरालाई इन्क्लुडिङ सीपीडी अब एडिशनल फिचर्समा चाहिँ तपाईहरुले यहाँ जोइन गरेपछि पाउनु हुने कुराहरु चाहिँ फ्री एक्सेस टु कम्प्रिहेन्सिभ डिजिटल अनलाइन लाइब्रेरी recorded videos will be shared for missed classes अब इन केस तपाईहरु कुनै अब आफ्नो रेगुलर क्लास त लिनै पर्ने हुन्छ त्यसमा अब आफ्नो विभिन्न कारणले कुनै क्लासहरु मिस भयो भने त्यो चाहिँ हामी तपाईलाई शेयर गर्छौं वीकली सी बेस्ड मोडल टेस्ट हाम्रो वीकली तपाईको मोडल एक्जाम मोक टेस्ट एक्जामहरु हुन्छ त्यसपछि materials will be provided individual as taught in class जो चाहिँ तपाईको अनलाइनबाट क्लास लिनुहुन्छ हैन तपाईहरुलाई चाहिँ पीडीएफ हरु शेयर हुन्छ र र जो चाहिँ हाम्रो क्लासमै आउनुहुन्छ फिजिकल क्लासमा आउनुहुन्छ उहाँहरूलाई ह्यान्डआउट पनि प्रोभाइड हुन्छ। त्यही सबै पढाएको कुराहरू सबैले आफैले पाउनु भएपछि तपाईँहरूलाई पछिलाई एउटा कन्टेन्ट्सहरू आफूसँग भएपछि रिभाइज गर्न सजिलो होस् भनेर त्यो चाहिँ हामीले सबै कन्टेन्ट्सहरू प्रोभाइड गर्ने गर्छौँ। यति नै हो बेसिक है तपाईको लागि ओरिएन्टेसनको लागि। पछि पनि हामी कन्स्टेन्ट टचमा हुन्छौँ। वाट एभर तपाईको कुनै पनि क्वेसन्स क्वेरिज कन्सर्न्स छ भने फिल फ्री टु सेयर। तपाईको प्याराडाइजको नम्बरमा हामीले त्यहाँ राखेको नम्बरहरुमा यु क्यान कनेक्ट विथ अस एन्ड जस्ट क्ल्यारिफाई वाट एभर यु हेभ है त। अब हामी धेरै टाइम नलिकन डाक्टर राजेश गुब्बा छ इन्डियन प्रोफेसर हुनुहुन्छ। उहाँ चाहिँ अहिले कृजकस्तान क्लास लिनको लागि कृजकस्तान जानुभएको छ। उहाँबाटै क्लासहरु लिँदै हुनुहुन्छ। ल Dr. Rajesh Gubba sir, so very warm welcome to you, and I'd like to just hand over the platform to you, and it's over to you, sir. Please carry on.
So thank you very much, sir, and a very good morning to all of you, and Subha Prabhatha.
Good morning, sir.
Good morning. Yeah, 1 second. Yes. So I hope everyone is able to see my screen over there.
Yes, sir.
Right. So I hope everyone will be comfortable in English because I don't know Nepali language. I'll learn by the end of your classes. Yes, I hope everyone will be.
Yes, sir.
Right. Okay. So in the today's session, we will try to take up one important topic in the endocrinology, right? From the internal medicine point of view. One important thing that you have to know regarding the internal medicine is very important subject in your day-to-day practice also. And you have to study and you have to read and you have to learn internal medicine, not just from the exam point of view, even for attending some medical emergencies and even for treating some common disorders like cough, cold, itching, difficulty in breathing, chest pain. So these are the common presenting symptoms what you will be coming across in your day-to-day life from your neighbors or from your relatives. So you should be able to handle these common scenarios, and you will be able to do that once you have a good knowledge on the topic of the internal medicine. And the very common disorder, endocrine disorder, which we come across in our day-to-day life, either from our neighbors or from our relatives, is the diabetes mellitus. So the very important knowledge, I mean, the thorough knowledge on the topic of diabetes mellitus is also very important for us. At least we need to treat these basic disorders. So like your idea of learning general medicine should be not for the entrance exams. Your idea of learning and reading the general medicine is like how to handle the common clinical scenarios which I come across. Like for example, once you enter into your post-graduation, definitely yes, you might become a dermatologist or you might become an orthopedician or you might become a radiologist. But again, if any patient is coming to you with cough and cold, and if you say that I am a dermatologist and I don't know how to treat cough and cold, that becomes a very embarrassing situation for you to handle that scenario at that moment of time. So general medicine, definitely yes, it's a very important subject, one of the very important subject among all the subjects that you have. So my sincere advice is to read and learn general medicine for saving the lives of the patient. And you should be, like the person given importance that for saving the life of the patient. Okay. So that is the basic introduction, what I wanted to tell you, the importance of general medicine. So now in the today's session, we will go ahead with one of the very, very important endocrine topic. Now I'll just show you. And so what we will do in this session, along with the theory topics, right? Along with the theory topic, I will also discuss some of the multiple choice questions related to the same topic, and I will just give you or one MCQ. You just let me know what would be the answer. So this is how the your question is. It has central obesity and abdominal skin showing the patient. Okay, anyone want to make it? What is that? Which option is that?
Option B.
It is Cushing syndrome. Is that what you have said?
Yes, sir.
Right, very good, excellent. So lady with central obesity and abdominal skin showing purple striae will be the Cushing syndrome. So what I want to discuss in this particular session is, I want to discuss the topic of the Cushing syndrome, right? So the next 1 hour or 1.5 hours, right, we will be discussing about the Cushing syndrome. And not only that, I will also show you how the questions will be asked on the same topic of the Cushing syndrome, right? So let us start with the session. And what I will do is, once the session is over, I'm also sending you this PDF. I will be sending this PDF to Dr. Amrish, and Dr. Amrish will share this PDF for you after the class is over. And regarding general medicine, let me tell you, if you read the content or the topic which is there in my PPT or PDF, that will be more than enough for you for your entrance MDMS entrance exam, right? So with this basic introduction, let me just go and discuss the topic. Okay, so what exactly you mean by the Cushing syndrome? Right, 1 minute. Right. So what exactly you mean by this Cushing syndrome? Cushing syndrome, it is a clinical condition which is characterized by increase in the steroid production. Right? Clinical condition which is characterized by increase in steroid production in the body. And that is what is nothing but your Cushing syndrome. Now, in order to understand, so what are all the things like we will be learning in the Cushing syndrome now? What are the etiologies causing Cushing syndrome? That is, what are the causes for Cushing syndrome? Then I will discuss the clinical features of Cushing syndrome. Then I will also tell you how to diagnose the patients with the Cushing syndrome and how do you treat the patients with the Cushing syndrome. Now, in the session when we are discussing, at any point of time, if you feel that I'm going a little fast, if you feel that if you are not understanding, right, I welcome you all to stop me at that moment, and you can ask me once again to explain that particular concept, whichever I am teaching you, right? I will not hesitate to repeat even 10 times, but my ultimate agenda is that all the students, whoever are attending the session, should be very happy at the end of the session. So if any student is not understanding any particular concept in the session, stop me there. Definitely, I will try to repeat. I will repeat whatever the concept you did not understand. Okay, right. So having said this, if you see the Cushing syndrome, it is a clinical condition which is characterized by increase in steroid production. Now, you need to know the basic physiology of the steroid production. So we have the hypothalamus, right? And this particular hypothalamus is the one which will produce the cortisol releasing hormone, CRH. Right, will produce cortisol releasing hormone, and this cortisol releasing hormone will come and act on the anterior pituitary, right, will come and act on the anterior pituitary. So anterior pituitary, in response to that, it will release the ACTH, that is adrenocorticotrophic hormone. Now this adrenocorticotrophic hormone will go and act on the adrenal cortex, right? And this adrenal cortex will produce the steroids. Now you need to know that the adrenal cortex, it has 3 layers, right? Adrenal cortex, it has 3 layers. So the outermost layer of the adrenal cortex, we call it as zona glomerulosa, right? And the middle layer, it is zona fasciculata, and the innermost layer will be zona reticularis. Now the question is, from which layer of adrenal cortex the steroids are being produced? So please remember, this is a very, very important point from the physiology point of view, that from zona fasciculata, the corticosteroids are being produced, or your steroids are being produced from zona fasciculata. Now, so this is the, right. Yes, so this is the basic physiology of steroid secretion. Now you need to be very much aware of what is called negative feedback mechanism. That is, when steroids are produced in excess quantity, what they will do is they will go and inhibit the ACTH secretion from the anterior pituitary, or they will go and inhibit the CRH secretion from the hypothalamus. So you have to remember that when steroids are produced in excess quantity, what will happen to your ACTH? The ACTH will be reduced. Right? What will happen to your ACTH is the ACTH will be reduced. And at the same time, the CRH is also reduced. Why? That is because of your negative feedback mechanism. So this is the basic physiology of the steroid production. Now, now we will come back to our Cushing syndrome. So Cushing syndrome, what is that we have discussed? That there is excessive production of the steroid production. 1 minute. Yes, there is excessive production of the steroids. Now, why there is excessive production of steroids? I will tell you the reason. For the excessive production of the steroids, the pathology is either at the level of adrenal cortex, or the pathology is at the level of the anterior pituitary. So when pathology is present in either of these 2 areas, either in the adrenal cortex or in the pituitary gland, there will be excessive production of your steroid. So this is about the basic physiology of the steroid production. So until now, all of you, have you understood this or not? The basic physiology of steroid secretion. All of you, have you understood this? And I think you have a chat box also. Right. I think you have a chat box also. So you can just, any doubts you have, you can just put it in the chat box, wherein I will see your messages in the chat box, and then I will answer if you have any doubts. Okay, right. One minute. Okay, right. Now we will move on to the etiology of increase in steroid production. That is etiology of the Cushing syndrome. Now, this is how the question can be asked. That is, the most common cause of Cushing syndrome is pituitary adenoma, adrenal adenoma, ectopic ACTH secretion, adrenal carcinoma. So this is the question that can be asked on what is the etiology of the Cushing syndrome. So can anyone answer this question? Make an attempt. Definitely, okay, yes, I do understand that you are listening the entire Cushing syndrome for the first time, but just make an attempt.
B.
What is the... Yes?
Answer B.
Adenoma.
Adrenal
Okay.
adenoma.
Adrenal adenoma. Okay, right. Okay, you have done a good attempt, but the answer in this question is, okay, we will discuss the etiology of the Cushing syndrome, and then we will come back to the same question, right? We will discuss the etiology and then come back to the same question. So now, what did I tell you for an individual to develop the Cushing syndrome, either the pathology is at the level of the anterior pituitary. What is that pathology at the level of anterior pituitary? That is because of excessive production of ACTH that will go and stimulate adrenal cortex, and thereby there is increased steroid production. Or the pathology can be at the level of adrenal cortex itself, where there is adrenal adenoma or adrenal carcinoma, and there is excessive steroid production. Now, if there is pathology at the level of the adrenal cortex, it is not dependent on the ACTH which is coming from anterior pituitary. Now, what is this? Let me try to tell you now. So now we will see the etiology of the Cushing syndrome, right? Etiology of the Cushing syndrome. So if you see the etiology of the Cushing syndrome, how is that we will classify is, we will classify that as the following. We have what is called ACTH dependent type of Cushing's, right? ACTH dependent type of Cushing's. And second, we have ACTH independent type of Cushing's, right? ACTH dependent and ACTH independent type of Cushing's. Now, what do you understand by this word, the ACTH dependent? The word ACTH dependent means there is excessive production of ACTH, and that is the reason why there is excessive production of the steroids. Now, let me think of the etiologies called the ACTH dependent type of Cushing's. Right? Let me take up the etiologies causing ACTH dependent type of Cushing's. So ACTH dependent type of Cushing's, let me tell you again, we have two etiologies. One, we have pituitary adenoma, which will cause excessive production of ACTH. And then the next what we have is ectopic ACTH production. Right? The next what we have is ectopic ACTH production. Okay, so this will be the etiologies for, right? This will be the etiologies for the ACTH dependent type of Cushing's. Now you need to know what is the, right? You need to know what is the type of pituitary adenoma. The type of pituitary adenoma, if you see, it is corticotroph type of pituitary adenoma. Now, what do you mean by this word corticotroph type of pituitary adenoma? Corticotroph type of pituitary adenoma is that which will be producing the ACTH. The cells what we have in the pituitary gland is corticotrophs, and these corticotrophs will be producing ACTH. And if there is tumor from these corticotrophs, we call it as corticotroph type of pituitary adenoma. Now, there are certain conditions where you have ectopic ACTH production also. Now, what do you understand by the word ectopic ACTH? The word is telling you, the word ectopic means the ACTH is being produced, but not from the pituitary gland. It is from outside the pituitary gland. Now, what are those ectopic sources of the ACTH? So, if you see the ectopic sources of ACTH, that includes, number one, small cell carcinoma of the lung, right? Small cell carcinoma of the lung. This small cell carcinoma of the lung, we also call as the oat cell carcinoma, right? We also call as the oat cell carcinoma. Next, and the other important etiology of ectopic sources of ACTH is Feochromocytoma. Now, what is Feochromocytoma? Feochromocytoma, it is a tumor which is originating from the adrenal medulla. Even that also can produce ACTH causing ectopic ACTH secretion. And other source for ectopic ACTH is medullary carcinoma of thyroid. What is medullary carcinoma of thyroid? Medullary carcinoma of thyroid is that where the tumor is originating from parafollicular cells of the thyroid gland, which we also call it as C cells of thyroid gland. And the other source for ectopic ACTH is bronchial carcinoids. right? Bronchial carcinoids. Okay, so these are all the ectopic sources of the ACTH. So now what all the etiologies we have discussed? I said you that the Cushing syndrome can be due to two reasons: ACTH dependent, where there is excessive production of ACTH; ACTH independent. ACTH independent means the increase in steroid production is not dependent on ACTH, which is coming from pituitary adenoma or pituitary gland, not from pituitary adenoma, pituitary gland. And what are those conditions which will cause ACTH independent? I will discuss. But ACTH dependent, we have pituitary adenoma and ectopic ACTH. Pituitary adenoma, what is that? Corticotroph type of pituitary adenoma where there is excessive production of ACTH. Then ectopic ACTH is that where the ACTH is being produced but not from the pituitary gland. Examples like small cell carcinoma of the lung, Feochromocytoma, medullary carcinoma of thyroid, which is originating from the parafollicular cells of the thyroid, and pancreatic and as well as bronchial carcinoids. These are all the causes for ectopic ACTH secretion. Now, then we will discuss what are all the conditions which will cause the ACTH independent conditions, right? ACTH independent. ACTH independent etiologies, they include number one, adrenal adenoma, right? They include adrenal adenoma, and then next we have adrenal carcinoma. So this adrenal adenoma and as well as adrenal carcinoma, let me tell you, they are not dependent on what is the quantity of ACTH which is coming from the pituitary gland. They are basically the tumors of the adrenal gland. Basically, they are the tumors of the adrenal gland producing excess amount of the steroids. That is nothing but your ACTH independent type of Cushing's. Now, having said this, now there are four important multiple choice questions related to the etiology. Right? Now, what are those four important multiple choice questions related to the etiology? Let me tell you. For suppose, right? For suppose, if the question is asked, right? If the question is asked, like, what is the most common cause of the Cushing syndrome? Now, what is that you have to answer? Let me tell you. Just 1 minute. Right. So, most common cause of the Cushing syndrome is, it is iatrogenic steroid production, right? Iatrogenic steroid supplementation. What do you mean by the word iatrogenic? Can anyone tell me what do you understand by the word iatrogenic?
We give
Yes.
a steroid for treatment of any disease condition.
Very good. Excellent. Super. So, iatrogenic steroid supplementation is, for example, the individual is suffering from some autoimmune disorders like myasthenia gravis. So there you give steroids for the treatment. But if you're giving steroids for long term, in increasing dose, the individual will end up in Cushing syndrome. That is the most common cause for Cushing syndrome. And if the question is asked, what is the most common cause of non-iatrogenic steroid supplementation? Most common cause of non-iatrogenic steroid supplementation, the answer will be pituitary adenoma. Right? The answer will be pituitary adenoma. And for suppose, if the question is asked like, right? If the question is asked like, what is the most common source of ectopic ACTH production? The most common source for ectopic ACTH production, that will be your small cell carcinoma of the lung. Right? That will be your carcinoma of the lung. And another question is, what is the most common cause of ACTH independent type of Cushing's? Most common cause of ACTH independent type of Cushing's, then the answer will be adrenal adenoma. Right? The answer will be adrenal adenoma. Okay. So these 4 questions related to the etiology is very, very important. Most common cause of Cushing's, iatrogenic steroid supplementation. Most common cause of non-iatrogenic Cushing's, that is your pituitary adenoma. And most common cause of ectopic source, most common ectopic source for ACTH production, that is small cell carcinoma. Most common cause of ACTH independent type of Cushing's, that becomes adrenal adenoma. Now, having said this, we will move on to the question what we were discussing just now. Yeah. Now you answer what is the answer to this question? The most common cause of Cushing syndrome is. Yes. Yes, I hope I am audible.
Pituitary adenoma.
Very good, excellent. So the most common cause of the Cushing syndrome here is pituitary adenoma. Why? Because your iatrogenic steroid supplementation is not given as an option here. So that is the reason why the answer is the pituitary adenoma, right? Very good. And so we have one student or one learner asking the question, sir, steroids inhibit CRH or not, or whether it's only ACTH level. Okay, so let me tell you, steroids will inhibit both ACTH and as well as the CRH, that is cortisol releasing hormone. Okay, it will inhibit both. Next, now one minute. So now we will move on to the clinical features of the Cushing syndrome. Right, the clinical features of the Cushing syndrome. Right. So now, yeah, can anyone answer this question, please? Cushing syndrome is not a feature of. Cushing syndrome is not a feature of.
Medulloblastoma.
Very good, superb, excellent. So you're answering very nicely. So the answer is medulloblastoma. Adrenal carcinoma will cause ACTH independent type of Cushing's. Port cell carcinoma of the lung will cause ectopic ACTH production. Pituitary adenoma will cause ACTH dependent type of Cushing's, and that is the most common cause for non-iatrogenic Cushing's. Next. Now we will move on to the clinical features in patients with the Cushing's. So if you see the clinical features in patients with the Cushing's, you need to know what is the earliest symptom or earliest change that you will observe in patients with the Cushing syndrome. The earliest change that you will observe in patients with the Cushing syndrome is the weight gain. Right? Weight gain, it is the earliest manifestation in patients with the Cushing syndrome. Now, why is that the individual will have weight gain? All that I will discuss subsequently now. Right. Okay. So coming on to, so if the question is asked, what is the earliest change? That will be your weight gain. Now, let me take up the discussion on in detail about the signs and symptoms of the Cushing syndrome. In detail about the signs and symptoms of Cushing syndrome. So we have the clinical manifestations regarding the appearance of the individual. And you know how will be the appearance of the individual? They will have moon-shaped face. Right? That is round face. Right? They have moon-shaped face. And second important thing is they have central obesity. Right? That is central obesity. That is accumulation of the fat around the abdominal area. And third important thing is they also have the buffalo hump. And this is how the appearance of the individual will be there in patients with the Cushing syndrome. And if you see the extremities of these individuals, they have very thin limbs. Right? They have very thin limbs. So, and you know what is this appearance called as in patients with the Cushing's? In patients with Cushing's, we call it as lemon on matchstick appearance. right? The appearance of the individual will be like lemon on matchstick appearance. Now, what is that lemon? Your lemon is nothing but central obesity. And what are those matchsticks? Matchsticks are nothing but your thin limbs. Now, you may ask me, sir, why does this appearance occur? Okay, so if you see the effect of steroids, right? If you see the effect of steroids on the fat, the effect of steroids on the fat is that these steroids on the fat, they cause lipolysis. That is, they will cause the breakdown of the fat. And thereby, there is excessive production of the free fatty acids. And these free fatty acids, whichever are being synthesized, right? These free fatty acids, whichever are being synthesized, they go and accumulate in various parts of the body. Like these excess free fatty acids, whatever are formed, they will go and deposit in the face. So thereby, they'll have moon-shaped face. These free fatty acids, they go and get deposited in the abdominal area. Thereby, they get the central obesity. And these free fatty acids, they go and get deposited at the nape of the neck. That is in the back of the neck. And thereby, they get an appearance called as the buffalo hump. So these will be, you know, the the appearance of the patients with the Cushing syndrome due to lipolysis, right? Due to lipolysis. Now, you should know, like, why there will be thin extremities, right? You should know why there is thin extremities. See, the reason for the thin extremities is that now at the same time, you should know what is the effect of steroids on the proteins, right? What is the effect of steroids on the proteins? So as your steroids are causing lipolysis, right? As your steroids are causing lipolysis, on the proteins, there will be proteolysis. Right? On the proteins, it will be proteolysis. So once there is proteolysis, what will happen? There is excessive production of the amino acids. Right? So now, where is your protein present? These proteins, let me tell you, they are present within the skeletal muscle of the extremities. They are present in the skeletal muscle of the extremities. So now, when there is excessive steroid production, whatever the proteins are there within the skeletal muscles of the extremities, they undergo proteolysis, and thereby there is excessive amino acid production. So thereby what will happen to your muscle? Muscle is completely degenerated. And how will be the extremities of the individual? The extremities, they appear very thin, right? The extremities, they appear very thin. So that is the reason why the appearance in individual with the Cushing syndrome, we call it as lemon, that is central obesity, on matchstick, which is nothing but thin limbs. So this is the appearance of the patients with the Cushing syndrome. So I hope you people are following. Do you feel that I am going fast, or do you feel that the speed is adequate?
It's fine.
It's fine.
Okay, very good. Now, we will move on to the dermatological manifestations in patients with the Cushing's, right? Dermatological manifestations in patients with the Cushing syndrome. Now, what are the dermatological manifestations? Dermatological manifestations include, number one, skin atrophy. Now, why there will be skin atrophy in these individuals is now you have to know, right? You have to know that in epidermis, actually we have two layers within the skin. One is epidermis and as well as the dermis. And within the epidermis, we have totally 5 layers of the skin. Now, what are those 5 layers of the skin in the epidermis? Like we have stratum corneum, right? Then stratum lucidum. Then we have stratum granulosum, right? Then we have stratum spinosum. Then we have stratum basale. So these are the 5 layers of the skin, right? That is stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale in the epidermis, what I am talking about, in the epidermis. Now you need to know that whenever there is increase in the steroid production, right? Whenever there is increase in steroid production, this increased steroids, what they will do is they will cause the degeneration of the stratum corneum. Right? They will cause the degeneration of the stratum corneum. So once there is a degeneration of the stratum corneum of the epidermis, the individual will have skin atrophy. Right? The individual will have skin atrophy. That is one of the very important manifestation in case of Cushing syndrome, dermatological manifestation. And the other important skin manifestation is easy bruisability. I will show you the dermatological manifestations also. Now you need to know why there will be easy bruisability. The reason is that, right? The reason is that already the skin of the individual is atrophied. Now you take in the subcutaneous tissue. What is the subcutaneous tissue that we have? It is the fat. In the subcutaneous area, what we have is the fat. Now, what is the effect of steroids on the fat? The effect of steroids on the fat is it will cause lipolysis. Right? It will cause lipolysis. So now what will happen to the fat within the subcutaneous area? It is completely degenerated. So you don't have any subcutaneous fat now. So thereby, what will happen to the Cushing's? You know, even with minimal blunt injury, there will be easy bruisability. Why? Skin is atrophied, and subcutaneous fat which has to be present beneath the skin, that is also damaged. So with minimal injury over the skin, there will be easy bruisability in patients with the Cushing syndrome. And followed by that, so these two are your dermatological manifestations. So number one, there will be skin atrophy, right? There will be skin atrophy. And why is that skin atrophy? That is due to degeneration of stratum corneum. And there is also easy bruisability. Why there is easy bruisability? That is because of loss of subcutaneous connective tissue. Then, followed by that, we have few more dermatological manifestations. And what are those few more dermatological manifestations? And these few more dermatological manifestations include the striae. And you know what will be the color of the striae? The color of the striae will be the purple striae. Now you have to know why they have this particular striae. So we have discussed that the skin is atrophied and there is no subcutaneous fat, and because of which there is easy bruisability. Now underneath the skin, right? Underneath the skin, which has undergone underneath the skin, what is happening? There is accumulation of the free fatty acids. Right? There is excessive accumulation of the free fatty acids. So once there is excessive accumulation of the free fatty acids, what will happen to the skin? The skin is stretched. Once the skin is being stretched, the individual will have the striae, and the color of the striae is nothing but your purple striae. Right? Next, the other important dermatological manifestation is the fungal infection. So why do you think there is fungal infection in patients with the Cushing syndrome? Now, can anyone tell me what is the effect of steroids on the immunity of the individual? Can anyone tell me what is the effect of steroids on the immunity of the individual? Any one of you, please?
Decreased immunity.
Very good. Excellent. So steroids will reduce the immunity of the individual. Now, in patients with the Cushing syndrome, what is happening? There is excessive steroids. So once there is excessive steroids, there is more and more decrease in the immunity of the individual. So once there is more and more decrease in the immunity of the individual, they are more prone for fungal infections. And you need to know what is that common fungal infection that you will come across in patients with the Cushing syndrome. And that particular fungal infection is the Tinea versicolor. Right? That particular fungal infection is the Tinea versicolor. Okay. So that is about the fungal infections. The other important point you need to know is about the hyperpigmentation. Now, why is that they have hyperpigmentation? Right? It's a we have a very good explanation for why there is hyperpigmentation in these individuals. See, I was discussing about the basic physiology of steroids, right? From the anterior pituitary, you have the ACTH which is being produced. Now, can anyone tell me, along with ACTH, what is being produced? Along with ACTH? Huh?
POMC.
So that is melanocyte stimulating hormone, right? Along with ACTH, MSH is being produced from the anterior pituitary. MSH is what? That is melanocyte stimulating hormone. So now the other point, what is that we have discussed? Like we have discussed the two important etiologies for Cushing's. That is ACTH dependent and ACTH independent. So in case of ACTH dependent, there is excessive production of ACTH. So when there is excessive production of ACTH, what will happen to your MSH level? There is also increase in the MSH level. Yes or no? Will you accept this or not? Yes. Will you accept that there is also increased MSH?
Yes, sir.
Very good. So now once there is increased MSH, right? What is melanocyte stimulating hormone? Melanocyte stimulating hormone is that which will cause the pigmentation of the skin. So once there is increased MSH, right? Once there is increased MSH, so what do you think will happen to the pigmentation of the individual? So there will be hyperpigmentation. So the hyperpigmentation is seen only in ACTH dependent type of Cushing's. Right? It is present only in ACTH dependent type of Cushing's. Why? Because of excessive production of the MSH, that is melanocyte stimulating hormone. So these are the dermatological manifestations that you will come across in Cushing's. So to shortly recap, the dermatological manifestations include skin atrophy, that is because of degeneration of stratum corneum, easy bruisability, that is due to loss of subcutaneous connective tissue, striae, that is because of enlarging trunk, right? The striae, they are mainly seen over the trunk, and they're more prone for fungal infections, that is nothing but your tinea versicolor. Hyperpigmentation will be there mainly in case of ACTH dependent type of Cushing's. Now, let me show you the dermatological manifestations also, right? So this is your striae, right? This is nothing but your purple striae, okay? And this is your easy bruisability, right? So these are nothing but the bruises. Right? There will be easy bruisability. And this is nothing but hyperpigmentation. This is nothing but hyperpigmentation, which are seen over the knuckles. So now we have few more clinical manifestations in Cushing's that need to be discussed. Yes, please answer this. Anyone? Actually, yes, you should be able to answer this.
Red striae present.
Okay. Any other answer? Okay. One student said red striae. Any other? And this is how the questions can be asked.
Proximal muscle weakness.
Very good. So what this individual will have is the proximal muscle weakness. I have already taught you this, right? In the beginning, lemon on matchstick appearance. What are those matchsticks? Matchsticks are nothing but your thin extremities. So why do you get that particular thin extremities? That is due to excessive proteolysis. Now, it is not red striae. I have mentioned you very clearly that it is purple striae. What we have is purple striae, but not the red striae. And even edema also will be there. Why there will be edema, I will discuss. Why there will be edema, I will discuss. So we have two answers in this question. That is proximal muscle weakness is there, and as well as edema also will be there. Why they have edema, I will let you know. Okay, coming on to the proximal muscle weakness. So now, what are the proximal muscles in the lower limb? Like we have quadriceps in the anterior compartment of the thigh. Then we have adductor muscles on the medial compartment of the thigh. And we have hamstrings on the posterior compartment of the thigh. That is in the lower limb. Whereas in the upper limb, what are your proximal muscles in the upper limb? In the upper limb, the proximal muscles are biceps. Then we have deltoid. Then we have triceps. So there will be proximal myopathy. So why is that proximal myopathy? That is because of increased catabolic effect. Right, that is because of increased catabolic effect. So that is due to proteolysis, right, where there is excessive breakdown of proteins. Where there is excessive breakdown of proteins. Next, the other important manifestation in patients with the Cushing syndrome is the bone loss, right? That there is osteoporosis. Now you need to know why there is osteoporosis, right? You need to know why there is osteoporosis. So why there is osteoporosis is, what is the basic physiology of the steroids? See, these particular steroids, they will stimulate the osteoclast, right? They will stimulate the osteoclast. Now, what is the function of the osteoclast? Osteoclast is that which will cause the bone resorption. So, when in patients with Cushing's, what is happening? More and more steroids are there. So, there will be more and more osteoclastic activity. So, once there is more and more osteoclastic activity, more and more bone resorption will be there, and that will cause osteoporosis. And once there is osteoporosis, there is decrease in your bone density, and these individuals, they are more prone for fracture. Right? These individuals, they are more prone for fracture. That is, pathological fracture will be there. Right? Pathological fracture will be there. So that is about the osteoporosis story. Next. Then, yes. Now you need to know why there will be edema. So in these individuals, there will be also edema. Let me explain you the mechanism of why there will be edema. You have to know that whenever there is increase in steroids production, this increased steroid will go and act on the epithelial sodium channels. Right? They go and act on the epithelial sodium channels. Now, where are these epithelial sodium channels? These epithelial sodium channels, they are present on the distal convoluted tubule. Right? These epithelial sodium channels, they are present on the distal convoluted tubule. Now, what these epithelial sodium channels will do? Epithelial sodium channels will increase the sodium and as well as water reabsorption. Right? Epithelial sodium channels will cause increase in sodium and as well as water reabsorption. So once there is increased sodium and water reabsorption, the individual will end up in edema. So that is the mechanism why there will be edema in patients with the Cushing syndrome. That is because of when there is increase in steroids, there is increased activity of epithelial sodium channels. Once there is increased activity of epithelial sodium channels, there is increased sodium and water reabsorption. And these epithelial sodium channels, they are present on the distal convoluted tubule. Right? So that is about the story related to your Cushing's. That is proximal muscle weakness and as well as the edema. Next. Yes. This is another way how the question can be asked on Cushing syndrome. So anyone want to make an attempt of this question? Which of the following features are not seen in Cushing syndrome?
Hypoglycemia.
Excellent, superb, very good. So hypoglycemia will not be seen in Cushing syndrome. And why there will not be hypoglycemia? Let me discuss that also in detail. Okay. So these patients with the Cushing's, they have what is called glucose intolerance. Now, why do they have this glucose intolerance? Steroids, let me tell you that they increase hepatic gluconeogenesis. Right? They increase hepatic gluconeogenesis. That is the basic physiology of the steroids. So, in patients with Cushing syndrome, what is happening? There is more steroids. So when there is more steroids, there will be more hepatic gluconeogenesis also. And once there is more hepatic gluconeogenesis, the individual will have increase in the glucose levels. And at the same time, you should know what do you mean by the word the gluconeogenesis. Gluconeogenesis means the conversion of non-carbohydrate moieties to the glucose. I'll repeat it. Conversion of non-carbohydrate moiety to the glucose. What are those non-carbohydrate moieties? Like amino acids, proteins, vitamins, minerals, they are converted into glucose. That is what is called as the gluconeogenesis. Next, the other point is these patients, they also have the hypertension. Now, why is that in patients with the Cushing syndrome, they have hypertension? Let me explain you the mechanism also. See, we have epinephrine and as well as norepinephrine, right? Epinephrine and norepinephrine, which are being released from the adrenal medulla. This epinephrine and norepinephrine, let me tell you, they go and act on the alpha receptors, right? They go and act on the alpha receptors which are present within the blood vessel wall, right? Which are present within the blood vessel wall. So you have to understand, or you have to know that whenever these alpha receptors are activated, or when the number of alpha receptors are more, there will be more vasoconstriction, and thereby there will be increase in your blood pressure. Now, what these steroids will do? These steroids, right? What these steroids will do? Steroids will upregulate the alpha receptors, right? Steroids will upregulate the alpha receptors. Now, what do you mean by the word upregulating the alpha receptors? What the steroids will try to do is, steroids will try to increase the number of alpha receptors in the blood vessel wall. I'll repeat the point. Steroids will try to increase the number of alpha receptors in the blood vessel wall. So once they increase the number of alpha receptors in the blood vessel wall, what will happen? More and more epinephrine and norepinephrine will come and act on that alpha receptors. More and more vasoconstriction will be there, and thereby there will be hypertension within the individual. So the cardiovascular manifestation is that whenever there is increase in steroids, there will be increase in the blood pressure within the individual as well. Okay, next. So to summarize, glucose intolerance will be there. That is because of hepatic increase in gluconeogenesis. And there will be hypertension. Why there will be hypertension? That is because of the upregulation of the alpha receptors by your corticosteroids, right? So that is the reason why there will be hypertension within the individual. Next, now these patients with the Cushing syndrome, they also have the thromboembolic events. So there is increase in the, right, increase in the formation of the clot, right? And they also have neuropsychological changes, which we call it as psychosis, right? Which we call it as psychosis. Now, why do these individuals have psychosis? Let me explain you. The basic physiology is that steroids, right? What the steroid nothing but your psychosis. Okay, so next, yeah, these are your neurological manifestation. Then followed by that, you take, yes, so features not seen in Cushing syndrome is what? Hypoglycemia will not be there. In fact, what will be there? There will be hyperglycemia. In fact, what will be there is hyperglycemia will be there in patients with the Cushing syndrome, but not hypoglycemia. And the remaining all will be there. Hypertension will be there, frank psychosis will be there, and even hypokalemia also will be there. Now you may get a doubt, sir, why there is hypokalemia? What did I tell you? When there is increase in steroids, this increased steroids will go and stimulate the epithelial sodium channels, and we call them as ENaC channels. Now, what is the function of these particular ENaC channels? The function of the ENaC channels is sodium and water reabsorption and potassium excretion, right? So, whenever these ENaC channels are stimulated, what will happen? There is increased sodium and water retention. There is increased sodium and water retention. But what will happen to your potassium? There will be potassium excretion. Right? And that is the reason why there will be hypokalemia. That is the reason why there is hypokalemia. So in patients with Cushing syndrome, please remember there is edema that is due to increase in sodium water retention, and there will be hypokalemia that is due to potassium excretion. Right? So this is about the electrolyte. So now if the question is asked, what will be the electrolyte abnormality in Cushing's? Electrolyte abnormality in Cushing's is that sodium levels will be more, potassium levels will be less. That is about the electrolyte abnormality in Cushing's. Yeah, please answer this. All are the features of the Cushing's disease except
Episodic hypertension.
very good. So they will not have episodic hypertension. What they have in patients with the Cushing syndrome is they have what is called sustained hypertension will be there. Right? Sustained hypertension will be there. That means the blood pressure will be increased for a longer duration of time. That is what is called as the sustained hypertension. And the remaining all, central obesity will be there, easy bruisability will be there, glucose intolerance will be there. Now you take the episodic hypertension. What do you mean by the word episodic? Means the blood pressure is increased occasionally. That is called episodic hypertension. And this particular episodic hypertension, it is a feature that you will come across in patients with the Feochromocytoma. So in patients with Feochromocytoma, you have this episodic hypertension, but not in patients with the Cushing syndrome. Right? Next. Now, in females with Cushing's, right? In females with Cushing's, they have the menstrual irregularities. Right? They have menstrual irregularities. And that particular menstrual irregularities will be in the form of oligomenorrhea and as well as the amenorrhea. So amenorrhea, everyone is aware of. Amenorrhea means where there is complete absence of the menstruation. And oligomenorrhea is what normally the menstrual cycle, which has to occur for every 28 days. In case of patients with oligomenorrhea, it will be after 35 days. Right? The cycle will repeat for every 35 days. And not only that, there is also decrease in the quantity of the menstrual fluid. That is called oligomenorrhea. So the frequency of the menstruation will be reduced and the quantity of the menstrual fluid also will be reduced. That is what will happen in the oligomenorrhea. And the other important point I wanted to ask you, in females, please tell me, will there be release of testosterone? Yes, in females, will there be release of testosterone in the body in females?
Yes.
Yes, sir.
Yes, the testosterone is being produced in females. Now, from where the testosterone is being produced in females?
Adrenal.
Zona reticularis.
Very good. That is zona reticularis. That is from the adrenal gland. So now in case of Cushing's, what is happening now? In case of Cushing's, there is adrenal hyperactivity. There is increase in the adrenal gland synthesis. And you know what will happen in patients with the Cushing's? Because of increased adrenal activity, there is increase in testosterone production in the females with Cushing's. And because of increased testosterone production in females, they have the signs of androgen excess. Now, what are those signs of androgen excess? The signs of androgen excess, it includes increased libido. Now, what do you mean by the word increased libido? Libido is nothing but the sexual desire. So now in females with Cushing's, there is excessive production of testosterone, and that is the reason why there is signs of androgen excess that includes increased libido. And not only increased libido, the other manifestations of the androgen excess will be hirsutism, where there is excessive growth of body hair. And increased libido, I have said you, there will be oily facial skin and as well as virilization. Now, what do you mean by the word virilization? Virilization means the muscles in females will turn similar to that of males. That is called virilization. And even there is increase in the size of the vocal cords, and thereby the voice, it becomes very hoarse voice. And you take the shoulders, they become a broad shoulders. And the clitoris, there will be increase in the size of the clitoris in females. That is nothing but the virilization. And these are all the signs of androgen excess in women, right? So these are the clinical manifestations that you will come across in patients with the Cushing's. So let me just do a short recap, right? So let me see how much you have understood. What is the earliest symptom of Cushing syndrome?
Wait again.
Weight loss. Weight gain.
Weight gain. Weight gain will be the earliest symptom of the Cushing syndrome. Now, what will be the appearance of these patients with the Cushing syndrome called as?
Lemon on matchstick.
Lemon.
Yes. So why is that they have the thin extremities?
Proteolysis.
More proteolysis.
That is because of proteolysis, excessive proteolysis within the skeletal muscles of the extremities, right? And why do they have this buffalo hump and central obesity?
Due to deposition of free fatty acid in the nape of the neck.
Deposition.
Very good, excellent. So there is excessive deposition of the free fatty acids in the nape of the neck and as well as in the central abdominal area, right? And in which type of Cushing's you have hyperpigmentation?
ACTH dependent.
Dependent.
Right, ACTH dependent type of Cushing's, there is hyperpigmentation. And which fungal infections are very common in these individuals?
Tinea versicolor.
Tinea versicolor. So why is that these individuals are more prone for fungal infections?
Decreased immunity.
Decreased immunity.
Yes, that is because of decreased immunity, they are more prone for the fungal infections, right? Next, the other important dermatological manifestation what we have seen is purple striae. So why do you think they have purple striae in these individuals?
Deposition of free fatty acid beneath the skin that stretches the skin and causes the striae.
Very good, superb, excellent. Now, why do these individuals have hyperglycemia?
Hepatic gluconeogenesis.
That is because of, yes, because of increase in your hepatic gluconeogenesis. And why there is excessive bone fractures in these patients?
Increased osteoclastic activity.
Yes, so because of increase in osteoclastic activity, there is increased bone resorption and thereby there is decrease in bone density, and that is the reason why they are more prone for pathological fractures, right? And why there will be hypertension in these patients with the Cushing's?
Increase upregulation of
Alpha receptor on the blood vessels.
and norepinephrine alpha receptors.
Very good. So there is increased upregulation of alpha receptors. And why there will be psychosis in this individual?
Increase activity of cerebral cortex neuron.
Right, very good, superb. So this is about the clinical manifestations in patients with the Cushing's. Now we will move on to how to diagnose the patients with the Cushing's. And sometimes you may also have clinical based questions in your exams, right? And this is how the question can be asked. Like a 23-year-old woman presents to the clinic complaining of months of weight gain, fatigue, amenorrhea, and worsening acne. She cannot precisely identify when her symptoms have begun, but she reports that without a change in her diet, she has noted a 12.3 kg weight gain over the past 6 months. And she has been amenorrheic for several months. On examination, she is noted to have the truncal obesity with bilateral purple striae across both the flanks. Cushing syndrome is suspected. Which of the following tests should be used to make the diagnosis of the patient? And the options are given to you. You just make an attempt. Anyways, we will be discussing that. You just make an attempt. Anyone?
24-hour urine free cortisol.
Free cortisol.
Right, very good. So whoever has answered the 24-hour urinary cortisol levels, that will be the best answer. Okay, now, so let me discuss how do you diagnose the patients with the Cushing syndrome now. For suppose, if the question is asked, right, for suppose, if the question is asked, what is the earliest biochemical change in Cushing's? What should you answer is, the earliest biochemical change in Cushing's is Loss of diurnal variation. Right? Loss of diurnal variation. Now, what do you mean by the word? Right? What do you mean by the word loss of diurnal variation? See, in a normal individual, early in the morning, the corticosteroid production will be very high. Right? Early in the morning means around 6 to 8 a.m. the corticosteroid levels will be very high. Okay? Whereas late in the evening, the corticosteroid production will be less. Right? That is around, if you take 12 a.m. in the midnight, the corticosteroid will be less. That is a normal physiology. But you know what will happen in Cushing syndrome? The diurnal variation, whatever is there, that is being lost. That means early in the morning also, the steroid production is very high. Late in the evening also, the steroid production will be very high. That is what is called as loss of diurnal variation, and that will be the earliest biochemical change that you will see in patients with the Cushing syndrome. So more steroids in the morning also, and excessive steroids even in the late evening or in the middle of the night. Even at 12 a.m. also, the steroid levels are very high in the individual. And that will be the earliest biochemical change. Now, what is the best investigation to confirm the hypercortisolism? The best investigation, let me tell you, different platforms give different answer. But what exactly is the answer? Let me tell you. That is, to increase in 24-hour urinary cortisol. Right, increase in 24-hour urinary cortisol. That will be the best investigation to confirm the hypercortisolism. Now, you should not do random cortisol. Why? Because this cortisol is being produced in a pulsatile manner. And at the point when you have taken the sample, the cortisol levels may be normal at that moment. So in order to see that we will not miss the diagnosis of hypercortisolism, we have to do a 24-hour urinary cortisol levels. Right? We have to do a 24-hour urinary cortisol levels. Okay. Next. Then followed by that, once your 24-hour urinary cortisol levels are elevated, what is the next step? The next step is you have to do the ACTH levels. Right? You have to do the ACTH levels. Now, what will happen to your ACTH levels? ACTH levels, if you find that ACTH levels are increased, now tell me which type of Cushing's is that?
ACTH dependent.
Very good, super. So this is suggestive of ACTH dependent type of Cushing's. Right? ACTH dependent type of Cushing's. Now, for suppose you have done 24-hour urinary cortisol levels which are elevated, and you have done the ACTH levels, and you found that the ACTH levels are reduced, then what do you suspect?
ACTH independent.
Yes, so this will be ACTH independent type of Cushing's. This will be ACTH independent type of Cushing's. Now, why? Why is that in case of ACTH independent type of Cushing's, the ACTH will be reduced? The reason is that in ACTH independent, there is excessive steroid production by your adrenal adenoma or adrenal carcinoma. And that increased steroid will go and inhibit the anterior pituitary. And once it inhibits anterior pituitary, the ACTH production reduces. So, the second step is to check the ACTH. If ACTH is increased, ACTH dependent type of Cushing's. And if ACTH is decreased, ACTH independent type of Cushing's. Now, so once you make out that it is ACTH independent type of Cushing's, you have to do the CT abdomen. Right? You have to do the CT abdomen. So once you do CT scan of the abdomen, what is that you will be able to make out? You will diagnose if there is any adrenal tumor. You will diagnose if there is any adrenal tumor. So that is the importance of doing the CT scan if the ACTH is being reduced. Now, you take the first scenario, that is ACTH dependent type of Cushing's. Now, ACTH dependent, I said you, there are two important etiologies. What are those? What are the two important etiologies which will cause ACTH dependent?
Pituitary adenoma and ectopic ACTH like small cell carcinoma and others.
Very good, superb, excellent. So now what is the further workup? Now for suppose, right, if you find that the ACTH levels are elevated, what is the conclusion? That is ACTH dependent type of Cushing's. Now ACTH dependent, again, we have two etiologies, that is pituitary adenoma and ectopic ACTH production. Now you should be able to differentiate these two now. Now how you will be able to differentiate these two, let me tell you. What you have to do is, you have to do what is called as high dose dexamethasone suppression test. Right, you have to do what is called high dose dexamethasone suppression test. That means, what is this high dose dexamethasone suppression test? You know what you will do in this is, you have to give 2 milligrams of dexamethasone every 6 hours for 2 days. I'll repeat it again. You have to give 2 milligrams of dexamethasone every 6 hours for 2 days. Now, when you are giving dexamethasone, what it will do to the ACTH is, for suppose, if it is ACTH dependent type of Cushing's, this high dose dexamethasone will reduce the ACTH levels. Right, if it is from pituitary adenoma, right, if the ACTH is coming from pituitary adenoma, this high dose dexamethasone will reduce the ACTH which is coming from pituitary adenoma. But whereas, if the ACTH is coming from ectopic source, right, for suppose, if it is like ectopic ACTH, please remember and please understand that if it is an ectopic ACTH, this high dose dexamethasone will not be able to reduce the ACTH. Okay, high dose dexamethasone will only reduce the ACTH which is coming from pituitary adenoma. It cannot reduce the ACTH which is coming from the ectopic source. That is the importance of your high dose dexamethasone suppression test. Now, once you find that, right, once you find that the ACTH levels are reduced, you have to consider pituitary adenoma and you have to do MRI of the pituitary gland. Right, you have to do MRI of the pituitary gland. Now, what is the purpose of doing MRI of the pituitary gland? To look for the size of the pituitary adenoma. That is the purpose of doing MRI of the pituitary gland, right? And if it is like ACTH is not decreased by your high dose, ACTH levels are still high in spite of giving high dose, then you have to suspect small cell carcinoma of the lung or Feochromocytoma, medullary carcinoma of thyroid, or your pancreatic and bronchial carcinoids. And accordingly, you need to do the workup. So this is about how you have to work up or how you have to diagnose the patients with the Cushing syndrome. Now, regarding that, let me show you some of the questions. Okay, you see this? We have a 50-year-old male, a chronic smoker, he presents with history of hemoptysis. He was having truncal obesity and hypertension, and he had an elevated ACTH, which was not suppressible with high-dose dexamethasone. What would be the most probable diagnosis?
Ectopic ACTH.
Very good. So the answer is ectopic ACTH. So what did I tell you? That if it is an ectopic ACTH, in spite of giving high-dose dexamethasone, the ACTH levels will not be reduced. That is what is happening here. So in our patient, the individual is having features of Cushing's and he had an elevated ACTH level, and that is not suppressible even with your high-dose dexamethasone. Even with your high-dose dexamethasone. So that is suggestive of ectopic ACTH producing lung cancer. And this patient is also a chronic smoker. So what type of lung cancer commonly you will see in these patients?
Small cell carcinoma.
Small cell carcinoma, right? It is your small cell carcinoma, which is the one which is a source for ectopic ACTH. Right, which is the one which is a source for ectopic ACTH. Okay, right. So that is about the your ectopic ACTH producing lung cancer. Now, then followed by that, I will show you a few more questions on the investigations itself. Then later we will move on to the treatment part. Yeah, which of the following is the earliest manifestations of the Cushing's?
Loss of diurnal variation.
Right. So right. So loss of diurnal variation, that is the earliest manifestation of patients with the Cushing syndrome. And I'll show you few more questions, very interesting questions. Treatment we will come in the last. Yeah, you see this. Which of the following is the most common cause of hypercortisolism?
Pituitary Cushing's disease.
No.
Prednisolone use.
Prednisolone use. Okay. So most common cause of hypercortisolism is iatrogenic, right? So prednisolone use is the one, it is iatrogenic. That is the most common cause for hypercortisolism. Okay. Next. Which of the following would you do first to confirm the etiology of hypercortisolism?
ACTS level.
High dose dexamethasone suppression test.
No.
ACTH level.
ACTH level. Right. So you have to do 24-hour urinary cortisol levels, and if it is elevated, now you need to know whether it is ACTH dependent type of Cushing's or ACTH independent type of Cushing's. Right. So you have to do ACTH level to differentiate whether it is ACTH dependent or ACTH independent. Okay. Right. So the answer is ACTH level. Right. You see the next question. Which of the following would you do first to confirm the etiology of hypercortisolism in a person with an elevated ACTH level?
High dose dexamethasone suppression test.
Right. Yes. So now the answer is yes. High dose dexamethasone suppression test is the one which will rule out whether it is an ectopic ACTH or whether it is a pituitary adenoma. Whether it is a pituitary adenoma. Okay. Next. Which of the following would you do first to confirm the etiology of hypercortisolism in a person with decreased ACTH levels? Decreased ACTH. Not MRI of the pituitary. See, when there is decreased ACTH levels, what is it suggestive of? Is it suggestive of ACTH dependent? No, do you suspect ACTH dependent or ACTH independent?
ACTH independent.
Yes, ACTH independent. What are the etiologies? Adrenal adenoma and adrenal carcinoma. So what is that you have to do?
CT scan of abdomen.
CT scan of the abdomen to rule out if there is any adrenal tumors. Okay. Next. Now, what is the importance of this inferior petrosal sinus sampling? Why you should do inferior petrosal sinus sampling? Now, I have said you that if the ACTH levels are elevated, you have to do high dose dexamethasone suppression test. And if high dose dexamethasone suppression test, if it shows that the ACTH levels are reduced, it is suggestive of pituitary adenoma. And if the pituitary adenoma, if you are suspecting, you need to do MRI of the pituitary. And if MRI of the pituitary, if it shows pituitary adenoma, well and good, no problem. You have a diagnosis. But for suppose, right, you have done a high dose dexamethasone suppression test, right? A high dose dexamethasone suppression test, ACTH levels are reduced, and you are suspecting pituitary adenoma. You have done MRI of the pituitary, right? You have done MRI of the pituitary gland, but surprisingly, your MRI of the pituitary gland was found to be normal. right? Surprisingly, it was found that MRI of the pituitary gland is normal. So if you now, what is that? You are suspecting Cushing's, but MRI of the pituitary gland is normal. What is that you have to do now? To confirm the pituitary adenoma, you have to do, right? You have to do inferior petrosal sinus sampling, right? And this inferior petrosal sinus sampling, what it will do, what is this inferior petrosal sinus? Inferior petrosal sinus is that where the pituitary gland will drain the venous drainage. And once you collect that inferior petrosal sinus sampling, and then you have to test for the ACTH levels, right? You have to test for the ACTH levels. And if the ACTH levels are elevated, then you have to suspect pituitary adenoma. That is the importance of your inferior petrosal sinus sampling, right? So now, okay, now let me just summarize all the investigations. You answer this question now. Which of the following would you do first to confirm the etiology of hypercortisolism in a person whose ACTH level suppresses in response to high dose dexamethasone?
Inferior petrosal sinus sampling.
No.
MRI of pituitary.
First,
MRI of
MRI of pituitary.
right. So you have to do MRI of the pituitary. When will you do inferior petrosal sinus sampling? That
If
is
MRI is
normal.
if MRI is normal, then you have to do this inferior petrosal sinus sampling, right? Not directly inferior petrosal sinus sampling, okay? Right. So this is the summary of the diagnostic testing. Whatever we have discussed now, this is just a summary. You see, the first step is to confirm hypercortisolism with a 24-hour urinary cortisol, right? And if the test is equivocal, then we will do overnight dexamethasone suppression test. Leave about that, no one is doing in the recent days. Second step is to confirm the source. You have to do ACTH levels. If ACTH levels are low, you have to do CT scan of the adrenal gland. If the ACTH levels are high, you have to do high dose dexamethasone suppression test to make out what is the source for ACTH. And if there is suppression of ACTH, you have to do MRI of the pituitary. If there is no suppression of the ACTH, then you have to do CT scan of the chest to look for ectopic focus. That is medullary carcinoma of thyroid or like your small cell carcinoma. You have to check for the source. Now, for suppose if the MRI of the pituitary is unrevealing, you have to do petrosal sinus sampling for the ACTH possibly with CRH stimulation, right? If the MRI of the pituitary is normal, then you have to do the inferior petrosal sinus sampling, okay? So this is the summary of diagnostic testing for hypercortisolism. So please tell me, have you understood how to diagnose or not? If any doubt is there, please text me. I will definitely answer you. Okay, I have many questions. Okay, so one question is, sir, whether ectopic ACTH will also cause hyperpigmentation? Yes, Pandit Ravi, ectopic ACTH usually will not cause hyperpigmentation. It is only pituitary adenoma which will be causing your hyperpigmentation, right? It's a very, very good question. Right. And Pandit Ravi is asking, what is the mechanism for increased clot formation? See, these individuals, they are more prone for, they have increased thromboembolic events. Why is that? Because there is increased lipolysis and there is free fatty acids, and these free fatty acids will go and get accumulated in the form of clot within the blood vessel. These free fatty acids will go and get accumulated in the form of clot in the blood vessels, and that is the reason why there is clot formation, right? Yes, Pandit Ravi, did you understand this?
Yes, sir.
Right, good. Yes, Monica is asking, so please repeat how about how inferior petrosal sinus sampling. Okay, so let me just revise that. Okay, see, what is the importance of the inferior petrosal sinus sampling? The importance of inferior petrosal sinus sampling is that, like for suppose, you are suspecting pituitary adenoma, right? And in the suspicion of pituitary adenoma, you have done MRI of the pituitary gland. But surprisingly, MRI of the pituitary gland is normal. Then still you are suspecting Cushing's. What you have to do? You have to do the you have to do inferior petrosal sinus sampling. Now, what is the purpose of doing inferior petrosal sinus sampling? Because pituitary gland will drain its venous drainage into the inferior petrosal sinus. So if there is pituitary adenoma, and if you take this blood sample from the inferior petrosal sinus, you will observe that there is increased ACTH, right? You will observe that there is increased ACTH. So that is about your inferior petrosal sinus sampling. So who was that? Someone of you were asking me. Monica. Yes, Monica, is that clear, Monica?
Yes, sir.
Very good. Now, we will move on to we will move on to how to treat these patients with the Cushing syndrome. This is the last part of the topic, right? Another 10 minutes, we will wind up the session. Right. So this is how the question can be asked. Patient So patient having Cushing syndrome due to adrenal tumor. What is the drug to be given? Cortisol, betamethasone, ketoconazole, fludrocortisone. So what is that you think that you have to give? Any guesswork?
Ketoconazole.
Very good. So the drug of choice is the ketoconazole. Now, why the answer is being ketoconazole? Let me explain you. So this is the medical therapy, right? These are the drugs for medical therapy. And what are those drugs for medical therapy is, we have the adrenal enzyme inhibitors. Examples of adrenal enzyme inhibitors is, we have ketoconazole. Not only ketoconazole, apart from ketoconazole, we also have the intravenous etomidate. Now, you might be having a doubt now, why do we give etomidate, intravenous etomidate? Why do we give this ketoconazole and as well as the etomidate? Let me explain you. They are your adrenal enzyme inhibitors. That is, for the synthesis of steroids, you see this point now. Yes, for synthesis of glucocorticoids, right? For synthesis of the glucocorticoids, where is this glucocorticoid synthesized from? That is from cholesterol. From cholesterol, you get the glucocorticoids, right? From cholesterol, you get the glucocorticoids. And what is the enzyme which is required? That is 11-beta hydroxylase and as well as 17-alpha hydroxylase. So this 11-beta hydroxylase and as well as 17-alpha hydroxylase, they are the one which will convert the cholesterol to the glucocorticoids. And whenever you give ketoconazole and whenever you give intravenous etomidate, what it will do, it will inhibit this 17-alpha hydroxylase and it will also inhibit the 11-beta hydroxylase, and thereby steroid synthesis does not occur. That is how the ketoconazole and as well as the intravenous etomidate work, and they are considered as the adrenal enzyme inhibitors. Next we have the adrenolytic agents. Now, what are the examples of your adrenolytic agents? The examples of adrenolytic agents is metotane. Right? The examples of adrenolytic agents is metotane. What is metotane will do? Will cause the lysis of the adrenal gland. That adrenal adenoma or adrenal carcinoma, whatever is there, will be lysed. That is what is your adrenolytic agents. Now, for suppose, if there is pituitary adenoma, what are the group of drugs that you have to give is, you have to give these two important group of drugs, cabergoline, and as well as the paclitaxel. These are the drugs which will target the pituitary gland. These are the drugs which will target the pituitary gland. That is cabergoline and as well as the paclitaxel. Okay, so this is the medical therapy. But let me tell you, medical therapy is not the treatment of choice. The treatment of choice is the surgical resection of the tumor. Right? The treatment of choice is surgical resection of the tumor. Take out the tumor. If it is like pituitary adenoma, do pituitary surgery and take out that pituitary adenoma. If there is adrenal adenoma or adrenal carcinoma, cut that adrenal glands. Right? Take out that adrenal glands. So the point is that, for suppose you have taken out the adrenal glands, right? For example, there is bilateral adrenal adenoma and you have cut both the adrenal glands. When you cut both the adrenal glands, what the individual can land up in? The individual will have hypocortisolism. So in order to prevent that hypocortisolism, what we do is we do a replacement glucocorticoid therapy, right? That is, we give hydrocortisone and we give dexamethasone. And this we call it as replacement glucocorticoid therapy, right? So that is about the medical therapy of Cushing's. But what is the treatment of choice? The treatment of choice will be surgical resection of the tumor. And what are the indications for medical therapy then? What are the indications for medical therapy then? The indications for medical therapy is that, for example, the individual is not fit for surgery, right? The individual is not fit for surgery. Then you have to give medical therapy, right? Or you have an ectopic ACTH production which cannot be found, right? Which cannot be found. And that we call it as, one second, yes, that we call it as occult ectopic ACTH. What do you mean by the word occult? Occult means hidden. We don't know where exactly is that ACTH coming from. Then also you have to do medical management. And what did I tell you the first? Wherever surgery is contraindicated, that means the individual is not fit for surgery. There you have to give medical management. Okay. So, and not only that, that is control of hypercortisolism in preparation for surgery. That means you are taking the patient for surgical resection of the tumor next week. So until this week, you give medical management, right? And third one is, like, you have done surgery, but still there is recurrence of hypercortisolism, right? You have done surgery, but still there is recurrence of hypercortisolism. Then what you can do? You have to give medical management. Okay. So this is about, right? This is about the indications for medical management in patients with the Cushing syndrome. And what is that medical management? That is adrenal enzyme inhibitors, adrenolytic agents, replacement glucocorticoid therapy, and we have drugs that will target the pituitary, that is cabergoline and as well as the paclitaxel. And you have to know a syndrome that is called as the Nelson syndrome. What is this Nelson syndrome? See, for suppose, if the individual is having bilateral, right? If the individual is having bilateral adrenal adenoma, right? Or if the individual is having bilateral adrenal carcinoma, then what will you do? You will do the resection of the tumor, right? Once you do the resection of the tumor, what will happen to your steroid production? The steroid production is completely reduced. Once the steroid production is completely reduced, what will happen to your ACTH level? ACTH levels are increased. Now, along with ACTH, what is that I have taught you? MSH is also produced, right? MSH is also produced in increased quantity. So when MSH is also produced in increased quantity, that will result in what is called hyperpigmented skin, right? That will result in what is called the hyperpigmented skin, and that is called the Nelson syndrome, right? So I'll repeat it. When there is bilateral adrenal adenoma, what you will do? You will cut both the adrenal glands. Thereby, what will happen to your steroid production? It is completely reduced. And as a part of your feedback mechanism, what the pituitary will try to do? Pituitary will try to increase more and more ACTH. And along with ACTH, you know that there is also MSH production. And whenever there is increased MSH, there is more pigmentation also. And that hyperpigmented skin, secondary to your bilateral adrenal adenoma resection, is called as the Nelson syndrome. Right? Is called as the Nelson syndrome. And one more important part of the treatment is, for suppose, what did I tell you? You have an ectopic source of ACTH production. And what is the ectopic source? The most common ectopic source is the small cell carcinoma of the lung, which is nothing but, right? Which is nothing but the oat cell carcinoma. And what is the treatment that you have to give if there is oat cell carcinoma? You have to give cisplatin and as well as the irinotecan. You have to give cisplatin and as well as the irinotecan. So that will be the treatment for the oat cell carcinoma of the lung. Okay, so this completes the discussion of the Cushing syndrome, right? So do you want me to do a quick recap of the topic?
Yes, sir.
Right. So we will do a quick recap of the topic. Okay, before that, Pandit Ravi is asking, what is POMC? POMC is nothing but it's a precursor for your MSH, that is pro-opiomelanocortin, right? Pro-opiomelanocortin, and that will be the precursor for your, right? That will be precursor for your melanocyte stimulating hormone. Okay, so now let me do a quick recap on the topic of the Cushing syndrome. So what is the most common cause for Cushing's? That is iatrogenic steroid supplement. Yeah, so I'll do a quick recap so that everyone will be able to follow. Most common cause of Cushing syndrome is the iatrogenic steroid supplementation. And most common cause of non-iatrogenic Cushing's is the pituitary adenoma. Most common cause of ectopic source for ACTH production will be small cell carcinoma of the lung. Most common cause for ACTH independent type of Cushing's will be adrenal adenoma. That is about the etiology. And earliest clinical manifestation in Cushing syndrome will be weight gain. The appearance of a patient with the Cushing's will be Lebanon matchstick appearance, where the individual will have buffalo hump, central obesity, moon-shaped face, and thin extremities will be there. And skin manifestations are skin atrophy will be there, easy bruisability will be there, purple striae, hyperpigmented skin, fungal infections. And if you take the metabolism, there is hyperglycemia. If you take the bone, there is osteoporotic bone. If you take the blood pressure, there is hypertension. If you take the CNS manifestation, there will be psychosis. And if you take the thromboembolic events, they are prone for formation of the clots. And in females with Cushing's, they have oligomenorrhea and amenorrhea. And they also have signs of androgen excess. That is like virilization, increased libido. And if you take the investigation, the earliest change will be loss of diurnal variation. But the very important biochemical abnormality that you will see on workup will be increase in 24-hour urinary cortisol levels. And once there is increase in your 24-hour urinary cortisol levels, you have to check the ACTH level. And once the ACTH level is elevated, you have to suspect the ACTH dependent type of Cushing's. If the ACTH levels is reduced, that is ACTH independent, for which you need to do CT of the adrenal gland. And if the ACTH levels are elevated, you have to do high dose dexamethasone suppression test. If high dose dexamethasone suppression test shows you that there is decrease in ACTH, you have to suspect pituitary adenoma, for which you need to do MRI of the pituitary. And if the MRI of the pituitary is normal, then you have to do inferior petrosal sinus sampling. Then we have discussed the treatment. The treatment of choice is surgical resection of the tumor. But if the surgery is contraindicated, right? If the surgery is contraindicated, then you have to give medical management. Medical management is you have to give adrenal enzyme inhibitor, that is ketoconazole, and as well as the intravenous etomidate. And what is the purpose of these? They will inhibit the enzymes which are required for steroid production. And we have adrenolytic agents, that is metotane. Okay, and we have the drugs that will target the pituitary, that is pituitary adenoma, that is cabergoline, and as well as the paclitaxel. And if it is an ectopic cause for your Cushing's, that is like small cell carcinoma, you have to give cisplatin and irinotecan. And you have to know about the Nelson syndrome. So whenever there is bilateral adrenal adenoma, you will do bilateral tumor resection. Thereby, steroid levels reduces, ACTH level increases, and along with that, even MSH is also increased. And once the MSH is increased, there will be hyperpigmented skin. That is called Nelson syndrome. Okay, so this completes the discussion of the Cushing syndrome, right? So please tell me, have you understood the topic or not?
Yes, sir. Thank
Right?
you,
Yes,
sir.
sir. Okay, so I'm typing my WhatsApp number, right? In the group just now, I have typed my WhatsApp number. If you have any doubts regarding general medicine, you can post me on my WhatsApp number, right? And I will reply you depending upon my free time. Immediately, I will try to reply whatever the doubts you have regarding the general medicine. And this particular notes, now whatever I have got, I will be just sending to Dr. Amrish, and Dr. Amrish will be sending you that particular PDF into your groups. Okay, so this is how the entire sessions of the general medicine will go. And at the same time, I will be also sending you some short clinical videos as and when the time permits. Okay, so shall I wind up the topic now? Shall I wind up the session? Do you have any doubts? You can text me. You can ask me if you have any doubts right now related to Cushing syndrome. I will be very happy to answer your questions.
Thank you, sir.
Thank you very much, sir. Okay.
WhatsApp number, sir.
So today and tomorrow we will be having this regular class. It's a regular class, but it's free for you. So this will be like a demo for you. And our regular class will resume our classes from. We'll keep like until Friday. We'll keep for registration, and from Saturday we'll just continue with Dr. Rajesh class. Okay. Okay, all of you, thank you for joining. Thank you, sir. Thank you very much.
Thank you very much. Thank you very much, sir. I will send you the PDF, sir. Please send to the students, sir.
Okay, sir. Thank you. Have a good day.
Thank you very much, sir.
Thank you, sir.
Thank you, everyone.
Thank you, sir.
Thank you, sir.